my slides show up as full screen for you? Or do you see like the web browser?
It's showing up as full screen on my end. Perfect. All right, so thank you everyone for joining today's seminar. Today we have Dr. Louisa Thompson from the Memory and Aging Program at Butler Hospital. She's also an associate professor within the Department of Psychiatry and Human Behavior at Brown University. Dr. Thompson uses her research to develop novel digital tools that administer cognitive screenings in older adults. And in particular, she seeks to identify and validate digital measures that are feasible for use in primary care settings and sensitive to the subtle cognitive and neuropathological changes associated with early stage Alzheimer's disease. And for those that don't know, the Memory and Aging Program at Butler Hospital is quite renowned for their work and their science in the Alzheimer's space. And with that, I'll let Dr. Thompson begin her talk, and we will carve out some time at the end for any questions that anyone has. So thank you so much for your time today, Dr. Thompson, and we're really excited to learn more about your work.
Well, thanks so much for having me, and I'm really excited to be connected with the Center for Digital Health. I have to note, an assistant professor still, though I aspire to be an associate professor in the not too distant future, hopefully. But yeah, I finished my fellowship actually here in the Memory and Aging Program a few years ago, and I've decided to stay on ever since. So, and I'm very excited to talk to you about how we're thinking about using digital cognitive screening tools in the context of Alzheimer's disease research. So my current research is supported by the Alzheimer's Association, specifically a clinician scientist grant, and I have no other disclosures today. So the goal of this presentation is to provide an overview of digital cognitive assessment methods in the context of Alzheimer's disease research. And I'm going to spend the first half of the presentation discussing how Alzheimer's disease is a huge problem and we need new tools for early detection and intervention. I'm going to talk about the limitations of what we're currently doing in terms of cognitive screening in this context. And then I'm going to talk about some new tests that are digital that we can use in the clinic and potentially use remotely, and provide some examples there of what I'm using in my own research. And then in the second half of the presentation, I'll talk a little bit about the work that I'm currently doing now called the DigiCog AD study, going over the design and aims, my protocol, and some of the challenges that we've had with COVID. And I'll go over my very preliminary findings so far in terms of adherence and acceptability. So Alzheimer's disease is a major public health concern in the United States. It's one of the most common causes of dementia, accounting for 60 to 80% of cases. And currently, we have about 5.8 million older adults living with Alzheimer's in the United States, but that number is projected to reach 13.8 million by 2050. So as people live longer and our ability to diagnose the disease is improving, we have higher and higher rates of Alzheimer's in our near future. And we've known for over 100 years now, actually, that misfolded proteins called amyloid plaques and tau tangles are the two main hallmarks neuropathologically of Alzheimer's disease in the brain. But we've come a long way in the last few decades in developing a more nuanced understanding of the progression of neuropathology in Alzheimer's disease. So thanks to innovations in neuroimaging specifically, We know that those amyloid plaques shown in the red line here, actually start building up in the brain 10 to 20 years before the onset of the recognizable clinical syndrome of Alzheimer's disease, characterized by memory loss and changes in day-to-day functioning. And then the amyloid plaques are followed by the accumulation of tau protein and then neurodegeneration or volume loss in the brain tissue. And all of these stages sort of occur across this progression of the disease. And really, a lot of these changes are occurring when somebody is still cognitively normal by traditional standards, using traditional screening methods. So there's been a major shift in the focus of Alzheimer's research as a result of these findings. We're very focused on developing therapeutics that can help with early intervention before there are major volume loss and other changes in the brain tissue. And earlier diagnosis of Alzheimer's is currently listed as one of the most important challenges in Alzheimer's disease research, according to the US National Plan to address Alzheimer's. Unfortunately, however, the biomarkers that we do have for early detection, things like amyloid PET imaging, are very costly and they're invasive. So they involve the injection of a radioactive tracer, and these scans are not widely available. And so we need better cognitive screening tools and other non-invasive measures in order to help us identify earlier on individuals that are in what we now call a preclinical stage of the disease before they begin to have mild cognitive impairment or progress all the way to dementia. Unfortunately, the current reality in clinical practice is very different. So in a recent Alzheimer's Association survey of primary care providers, 82% said that they were on the front lines of providing dementia care. So actually a lot of people are coming in when they've already got significant memory impairment and getting a diagnosis of dementia in the primary care setting. And part of the reason why this is because there's a shortage of specialized care for memory disorders and dementia. And my background is in neuropsychology, and it's a very specialized field where the evaluations to characterize cognitive changes and memory loss require a lot of specialized training and lengthy testing. And there are a lot of barriers to getting patients in for those types of services, and they are often done in a specialty clinic. And in the primary care setting, the current cognitive screening tools that we have, like the mini mental status examination, which many of you may have heard of, are not sensitive enough to detect small cognitive changes that occur in the earliest stages of Alzheimer's disease. And this is very well documented. The mini mental also has very poor specificity in underrepresented populations, such as racial and ethnic minority groups. And adjusting for education can help somewhat, but this tends to be done inconsistently in different settings. And really, the MMSE provides a textbook example of some of the measurement issues that we have for cognitive screening measures. So positive skew, restricted range, and ceiling effects when we apply these tools for healthy older adults. And we hope to look at mild cognitive impairment as well. So we see, in a screening measure that's scored out of 30, in healthy older adults, the majority of them are only losing 1 or 2 points on this measure. So we're not catching people with preclinical or prodromal Alzheimer's with the mini mental. And then some of you may also be familiar with the MoCA, the Montreal Cognitive Assessment. This is another very brief screening tool that's actually a bit better at detecting mild cognitive impairment, and it has an education adjustment built into the scoring system. But it is also plagued by various issues such as poor interrelater reliability when it comes to some of the scoring, particularly in the section where patients are asked to draw a clock. So actually, Catherine Price and her colleagues have shown that there's pretty low rate of reliability on this scoring system. It's just a three-point scoring system for the MoCA, but at least 2 training sessions are needed to improve the reliability for this part of the test. And then more generally, another broad challenge with cognitive screening is that it's often a single time point assessment. So somebody might come in for an evaluation of their primary care providers once a year. And, depending on how they're doing that day, they may be showing up as impaired on the screening measure, or they may be showing up as doing just fine. And there are a number of environmental and other health factors that play into whether or not somebody is maybe having some subtle variation in how they're scoring on those measures. And so you can start to see sort of false changes from one year to another potentially if you're trying to track somebody's cognitive function based on that single time point testing. So the shift of focusing on early detection for Alzheimer's really means that we need to re-examine how cognitive screening can be improved to detect subtle cognitive changes in the earlier stages of Alzheimer's disease. In particular, we need to think of ways to make cognitive screening more accessible and sensitive to facilitate early intervention before there are major changes in the brain. And we need to think outside the box about ways that we can approach cognitive assessment that can capture the more continuous nature of cognitive decline and within subject change in the context of Alzheimer's disease. So moving on to talk about some potential solutions. So digital cognitive assessment, very broadly, provides a lot of potential advantages for cognitive testing in any population. And the main reason for that is the potential to use automation with these tests. So automation in the delivery or scoring can reduce the training demands for clinicians or raters, and it can help improve the accuracy of scoring if scoring is done automatically. And having this automation means that the person giving the test needs less training, and the administration is more likely to be standardized and see less drift over time and across providers. Also, a number of digital platforms like tablets and smartphones can be more easily adapted for use in remote settings as opposed to having to always rely on in-clinic settings for testing. But we have to be careful with digital cognitive testing. There are really tons of digital cognitive tests flooding the market, specifically for assessment with older adults right now. And that's just because of the great need in this area. And we really need careful, independent research studies to demonstrate, whether or not these tools have good measurement properties, if they're reliable and valid, specifically in older adult populations. And some of these more commercial tools just really don't have that great of a support in the literature yet. So moving on, I'm going to talk highlight a couple of different measures that have been well validated, and these are all tools that I'm currently using in my research or in the clinic. So the TabCat is a tablet-based cognitive screening tool. It is a supervised cognitive test. And specifically, the Memory and Aging Program at UCSF has developed something called the Brain Health Assessment, which is a 10-minute series of 3 different tests consisting of a favorites learning or association learning test, a visual processing speed symbol matching test, and a visual spatial skills test, a basic line orientation test. So these 3 measures can actually be composited. There's an option to add additional measures as well. But the basic series of tests for the brain health assessment has shown really good discriminative validity in distinguishing normal cognition from mild cognitive impairment and dementia in the UCSF Memory and Aging Program research. It's also been shown that the brain health assessment used on the TabCat is positively correlated with both the MMSE and the MoCA. And there's actually a conversion that you can do, a simple scoring conversion, to extract a MoCA score from the composite score from the brain health assessment. So this is a test that we're actually using in place of the MoCA in our outpatient neuropsychology service right now. It's also available for free, which is great. And just this past year, there was a really exciting publication on the TabCat that came out showing that, you know, looking at the brain health assessment, so it's that 10-minute battery of tests that I mentioned that's used to generate a composite score, comparing that to the MoCA, we actually see much better ability to detect and distinguish between individuals who are cognitively normal and do not have any elevated amyloid in the brain versus those who are cognitively normal and have elevated amyloid. So these are people in the red line that we would consider to have preclinical Alzheimer's disease. But they're cognitively normal, you know, based on general tests like the MMSE in terms of their presentation and their complaints as well. Sorry again about the lawnmower. Is it loud for you guys? No. Okay, good. So you're really loud here, but it's okay. It's not bothering me as long as you can hear me. Okay. So another digital cognitive test that's quite different is the DCT clock, and this is a really cool tool. It's actually one of the first things that I learned about that got me interested in digital assessment measures, and it's basically just a digital pen that records a drawing, and it's used to collect traditional clock drawing test performance from patients. So the traditional clock drawing test has been around for many decades. It's a very popular bedside measure. And the instruction is just to draw a clock, analog clock face, set the hands at 10 past 11. And actually individuals with mild cognitive impairment or dementia have a lot of trouble with this. There's issues with planning, there's issues with conceptualizing the time, and the DCT clock takes that drawing performance and uses a machine learning algorithm to extract a lot more information than what the clinician can see just with their, you know, their naked eye. And so, for example, here you can see 2 drawings of a clock. Both of these, at first glance, are, you know, not really impaired looking. The time is accurate. The numbers are all there. They're generally circular looking. But the DCT clock is able to look at things like latencies in the amount of time it takes them to think through the task, and the spatial organization between the numbers, and is much better at detecting those subtle changes. So this is a simple test that can be administered in about 5 minutes, and it's actually already FDA approved. It has a cloud scoring system, so it has the potential to be integrated into electronic medical record type system, although nobody has done that yet. So last month, there were actually some really important findings published on the DCT clock from the Harvard Aging Brain Study. And specifically, they showed that the DCT clock had excellent discrimination between individuals with normal cognition and those with mild cognitive impairment. So an area of under the curve of about 0.86. And even more importantly, in individuals with normal cognition who had Alzheimer's biomarker data, they found that the DCT clock composite scores were associated with greater amyloid and tau burden in the brain. So that's determined using PET scans of the brain. And they compared the DCT clock, which is just a 5-minute data collection process, with a much larger cognitive battery, the preclinical Alzheimer's cognitive composite, and actually found that it did better than that larger battery of tests for discriminating between individuals with elevated versus non-elevated amyloid. So this is a really great new finding. Hold on just a second. Do you guys see that error message as well? Okay,
Yeah.
So strange. I'll stop sharing for just a second here and try this again. Just gonna refresh the page. Okay, I think we got it. Okay. You guys see the slide again? Okay. So the next tool I'm going to talk about is the online repeated cognitive assessment. And this is actually a tool that can be done completely remotely using a home computer. So in this task, it's an associate's learning task, and participants hear a word and then are shown a Chinese symbol. And their goal is to just guess at first if it's a match between the word that they hear and the Chinese symbol on the screen. And the test is completed in about 20 minutes, and it's done for at least 5 days. And over time, as the patient does the test, the proportion of correct matches versus non-matches between the English word and the Chinese character increases, so that the associations are gradually learned through an implicit process. And the ORCA test was first actually developed by the Australian Imaging Biomarker Lifestyle Flagship Study of Aging, or ABLE study, which is an ongoing longitudinal study at the University of Melbourne. And they looked at performance on the ORCA test over the course of 5 days and saw a very nice distinction between how the learning curves looked for younger adults, shown in the black line here, and cognitively normal older adults without any elevated amyloid in the brain, and then older adults who didn't have symptoms of Alzheimer's necessarily, but did have elevated amyloid. So even after just a few days of testing, they saw a much stronger learning curve in the younger folks, and then also a divergence between the amyloid elevated versus non-elevated older adults. So these were fairly small numbers, but more recently they published data from the same study with a larger sample of older adults with amyloid PET scan data. And again, they demonstrated this nice distinction in the learning curve between individuals with and without elevated amyloid. And this was seen really actually just after 2 or 3 days of testing, doing those 20-minute sessions I mentioned online with the test. And in the same paper, they also showed that the distinction between the amyloid elevated, amyloid non-elevated, and elevated individuals also related to the volume of parts of the brain that are implicated in Alzheimer's disease. So there's usually global volume loss, shown here, and hippocampal volume loss. And so the rate of learning differed for these two groups of individuals and interacted with volume. So I'm being mindful of time. I'm just going to move on quickly. The last test that I wanted to talk about is another one I'm currently using in my research study that I'm going to talk about in detail in a minute. And thinking more broadly, first about mobile cognitive testing, and whether or not it's a good idea to try to do this with older adults. There's actually some really promising or encouraging information out there from the Pew Research Center, and they have found that about 2/3 of baby boomers, so adults age 55 and older, report using smartphones at this point. And brain training apps. So, things like Lumosity have been adopted pretty regularly by seniors, and these are sort of gamified tasks that provide feedback over time, and so they're very engaging. But this still suggests that there's potential there for older adults to engage and persist with brain game type of apps on their smartphones. And also very important, it seems that the rate of smartphone use for all adults, so not specifically older adults, is similar among Black, Latinx, and white Americans. And this is really important because, especially in clinical trials and thinking about how to do cognitive assessment remotely in the context of COVID, we see a lot of barriers in terms of who has access to internet at home. And there's actually, a much more a good likelihood that different racial and ethnic minority groups have access to a smartphone and a data plan than necessarily to home internet use. So we think that there's a lot of potential to using a mobile platform for cognitive screening. So I'm going to talk specifically about the M2C2 app. This is the Mobile Monitoring of Cognitive Change app. And this tool is developed out of the Penn State Center for Healthy Aging, and specifically Marty Slowinski and his team there have a large U grant to study this and develop and study this tool over the course of several years. And it's in collaboration with them that I've been able to use this tool for my own research. So MTC2 is an app-based EMA platform, and it can be used to collect a number of different types of real-time measurements. So that includes self-report survey data, as well as cognitive testing. And in the literature, there are several tests, cognitive tests that have been used on the MTC2 app platform, measures of processing speed, working memory, and episodic memory. And these have been well characterized and published on in a couple of different papers in adults, so not older adults, but adults ranging from age 18 to 40. And these measures are typically collected in short bursts or several times a day over the course of 7 or more days. And looking across assessments on these cognitive measures, generally the reliabilities have been found to be really, really excellent. So ranging from 0.9 to 0.98. And they've also been shown to correlate with traditional neuropsych measures that are done in the clinic. So within the same cognitive domain, the app-based tests tend to correlate at least moderately with paper and pencil measures in younger adults. And very preliminarily, at a conference this past year, I did see some very encouraging data, specifically looking at older adult populations and showing that performance on the M2C2 cognitive measures correlates with cerebrospinal fluid measures of tau protein, and as well as amyloid PET imaging measures of amyloid accumulation. And just in this past year, the Einstein Aging Study, which is a large longitudinal cohort study, has started using the M2C2 app for remote cognitive assessment. And they've found excellent adherence in their sample, which consists of older adults both with and without mild levels of cognitive impairment. And you can see that over the course of a couple of weeks, completing multiple sessions a day, that both cognitively normal and individuals with MCI overall show pretty high rates of adherence with completing these cognitive measures on the M2C2 app. And the Einstein Aging Study has also shown, this is just, again, data from a conference recently, it has not been published yet, but they've shown that the specific measures shown here in red that they're looking at on the app actually have pretty good convergence with in-person measures of cognitive performance. So things like processing speed and working memory, visual spatial skills, and list learning correlate well with these measures. So before I move on, I just wanted to see if anybody had questions about some of the research that I've talked about before I summarize.
I have a question. So I'm sorry, I'm very new to this space and like thinking about Alzheimer's and all of this. So this is all new information to me. But are these tools and are these apps like sort of strictly used just for measurement, or is there some type of like cognitive exercise that this offers to people who might be trying to like maintain, I know that a lot of it is biological, but I'm wondering just like if it has like like positive clinical outcomes as well?
Mhm. Yeah, that's a really great question. And it's interesting that there's actually sort of a completely different world of cognitive remediation and rehabilitation tools that are used, particularly in veterans and individuals with traumatic brain injury, showing that using apps or internet-based brain training programs can actually result in better improvement in brain function in individuals with brain injury. And to a much smaller extent, those applications have also been looked at in older adults with very early stage cognitive decline, sort of to help them strengthen different cognitive abilities. But in this context that I'm talking about, and especially for clinical trials research, we're primarily using the measures, these tests as measurements for baseline cognitive function, and then monitoring over time whether or not there are changes.
Thank you.
Yeah. Any other questions?
Hi, Dr. Thompson, I have a question. I'm also new to this space, to the science of the Alzheimer's space as well. I've had family members that have, succumbed to it in the past, so I'm familiar with it from that perspective. I wonder what your thoughts are on what I'll call industry available screening tools or training games, and how the effect that has on care delivery versus scientifically validated tool that may be more may have been developed more in your wheelhouse as opposed to somebody working on the industry side.
Mm. Yeah, I think if I understand your question, it's sort of what are some of the advantages or disadvantages to those different approaches. Yeah. So, I mean, one thing that's really great on the industry side is there's, a lot more manpower and funding to actually get something into a place where it can be implemented and utilized more rapidly. So in academic research, we tend to sit around at all the different stages of research and try to carefully replicate studies before we actually even think about, doing a clinical trial or implementation research. And so that's definitely a barrier and something that we need to work on, not just developing these tools and then testing them in a really specific population, but also trying to look on a broader level at how we can fast track these measures into actual clinical practice. Because yeah, that's one of the challenges, is that the industry designed measures, which may or may not have validation, are actually making it into practice and being used potentially inappropriate or inappropriate ways. So we need to worry about that.
Great, thank you so much.
Question. Anybody else have a question?
Yeah, so hello, thank you. That was a great presentation. I'm a researcher at UCLA working on the depression space with digital health tools. And one of the, I guess one of the use cases kind of similar to the case in Alzheimer's is early detection and potentially prevention.
Mm-hmm.
But for Alzheimer's and in this space, do you think that, or what kind of protocol do you think would be useful for like a, sorry, let me rephrase this bit. So there's like the goal is to like have like something that's like continuously monitoring you, right? That's one of the biggest boons, I guess, of digital therapeutics. Because it's always on and you can always like have data added. What kind of screening procedure do you think might be implemented in the future or might be tested to try to get this continuous monitoring approach to like let someone know like your priorities are going to get something or?
Yeah, that's a really great question. I didn't really touch on that, but definitely there is some movement towards passive data collection and monitoring in the home, and using things like language, and functional data to extract information about very early stages of cognitive decline. So for example, running machine learning analytics on fluency or voice quality information in somebody, just having reading a story or having a conversation, or collecting information about motor function is another one that seems to be very promising. And that's also being done in Parkinson's research. So I think some wearables like smartwatches or actigraphy devices and things like that that can collect passive data also have a lot of promise in the field of Alzheimer's research.
Thank you.
Great. I'm gonna move on and just talk a little bit about the research that I'm doing now. So this is an ongoing study, the DigiCog AD study, that we're running at the Memory and Aging Program, and it's funded by the Alzheimer's Association. And this study started just this past fall. So it's a 2-year study. And this research is actually using a couple of the measures that I talked about, the M2C2 mobile app and the online testing ORCA test. And I'm interested in looking at the feasibility of using the M2C2 app and online cognitive screening in a specifically older adult sample recruited here at the Memory and Aging Program. So there's not a lot of published information out there on whether or not these tools can be used specifically in older adults. And I want to also, with this study, look at the impact of feedback expectations on participants' adherence and user experience. So I mentioned earlier that older adults have been quick to adopt brain training games like Lumosity, and part of the reason why that might be is because they can actually look at their performance over time and get feedback on how they're doing. And so in this study, I actually randomized individuals to receive feedback, to be told whether or not they would receive feedback at the end of the study, to see if going through the protocol of this testing online and with the app, they would have better adherence if they believed that they were going to get feedback at the end of the test. And I also wanted to look with this study at the convergent validity with these measures and in-person standardized cognitive tests. And finally, because the Memory and Aging Program, fortunately, does collect a lot of Alzheimer's biomarker information from participants, I hope to have some data on whether or not individuals have elevated amyloid in the brain and see if these tasks could potentially distinguish between amyloid PET positive and PET negative individuals, and see if I can replicate some of these findings, especially with the ORCA, showing that there are differences in the learning slope for individuals with elevated brain amyloid versus not on the memory-based subtests for the M2C2 app and the ORCA. So my target sample for this study is 150 cognitively normal older adults, so older adults without clinical diagnosis or memory impairment on standard measures. And they're anywhere between the age of 60 and 80. And I did specifically recruit individuals who have at least some background experience using smartphones. Just because of the scope of this grant, I did not have the resources to do a lot of training on how to use smartphones. And I have stratified my recruitment to collect, hopefully, equal numbers of individuals with elevated PET scan data, 50 without elevated PET scan data, and then 50 who haven't had PET scans at all, or PET naive participants, we call them. And so I was actually supposed to launch this study right about the time that COVID started. And as I mentioned, a component of what I was doing was going to be bringing people into the clinic to do in-person cognitive assessments, and actually wasn't able to do that. So I ended up moving the study to a fully remote protocol where we did everything for the screening, either on the phone or on a RedCap sort of online survey platform. And then we shipped them in the mail a study phone, an Android phone, and all the information that they needed for how to complete the remote assessments. So both the app-based tests and the online testing. And participants were randomized to either do 8 days of M2C2 followed by ORCA for 5 days, or the other way around. So the order of those two assessments was randomized. And for the ORCA, they did 20 minutes of testing a day. And for the M2C2, they did 3 sessions a day, both morning, afternoon, and evening sessions. And each session lasts only about 3 to 4 minutes. And then at the end of the study, I had everybody do an exit survey to see whether or not they enjoyed completing these assessments and get their input on how to make it better. So as I mentioned, we've been running the protocol remotely since August, was when we actually finally launched. And we have actually just finished this phase because we reached enrollment of about 50 participants in this remote phase of the study. And you know, it's actually interesting. We have a lot of studies here at the Memory and Aging Program, many of which involve in-person assessment. And so recruitment for this study was actually not very difficult. There were a lot of people who wanted to do something remotely. And so we were able to enroll them in the study, which was nice. So far the sample has been fairly homogeneous in the sense that we do have primarily female, higher education, and a skew towards primarily white Caucasian background in the study. And we've had some difficulty collecting or recruiting individuals with elevated amyloid PET data collected through our program, but we're working on improving that right now. And to determine whether or not individuals were cognitively impaired, we had them do the TICS, which is a telephone interview cognitive screening tool. So it's sort of designed to replace the MMSE, but it's administered via telephone. And it is scored out of 50 points. And we had an enrollment cutoff of 34, which is supposed to be roughly equivalent to MMSE of 25. So on the M2C2 testing platform, participants first did a couple of surveys. These were very, very brief questions just to get a sense of where they were, what they were doing when they got a beep on the phone to tell them that it's time for them to do their assessment. So the phone would beep, they would go into the app and it would tell them if there was a morning, afternoon, or evening survey available. And if they already have completed it, it would just say that there's currently nothing available for them to complete. And questions include things about sleep, what they're doing, if they're alone, how distracting is their environment, and so on. And this just takes about a minute to complete. And then they went on to do a color shapes test. This is a working memory measure. So they see some different shapes appear on the screen, and then they disappear and reappear, but in a different place on the screen. And for each trial, they have to decide whether or not the color of the shapes has changed or not. So they have to decide whether or not they saw the same color with the same shape previously. And so that component requires some visual working memory to make that decision. Next, they did a symbol search measure. This is a visual processing speed measure, looking at their reaction time for tapping which cards at the bottom of the screen match a card at the top of the screen. And then finally, they did a paired associates learning measure, which is called the shopping list test. And for this task, they just have to make a determination of whether or not a certain shopping item is fairly priced or not. So they say yes or no. Is the grocery item a good price? And then after they've seen about 10 grocery items, there's a recall portion where they have to remember the price of the item they were asked to consider. So they engage in sort of some decision making about whether or not the price is fair, and that hopefully allows them to encode that price so that they can remember it later on the delayed recall portion. So this is immediate delayed recall. This task only takes about a minute to go through. So overall, just really quickly, for this study so far, the adherence has been really great. It's pretty consistent with what I reported is the preliminary finding from the Einstein aging study. So about 50% of our participants have completed all 24 assigned sessions with the M2C2 app. But even better, actually 88% of them completed 19 of the 24 sessions. So that's 80% within the period. So most people missed one or two, but the vast majority of them completed at least 80% of the sessions, which is really great. We did not see any differences in adherence rates so far on the basis of demographics. So again, this is just our preliminary data with about 50 participants. But really interestingly, one thing that we'll have to investigate more is that it seems that participants who previously participated in research here in our program, where they learned about whether or not they had elevated amyloid in the brain, they tended to have much better adherence. I shouldn't say much better, significantly more adherence on the M2C2 sessions compared to people who were naive to their PET status and had not previously been in to learn that information here in the program. And our post hoc analysis for this actually shows that it didn't matter whether or not the participant had learned if their result was negative or elevated or not. Either result was associated with their adherence. So this suggests maybe there are some differences in motivation for participants depending on whether or not they've learned their Alzheimer's disease risk status through prior participation here. And I know I'm running out of time, so I just wanted to quickly say we have some preliminary data from our exit survey, and for the most part, the response, at least for the app, has been very positive. People have not enjoyed the online ORCA testing as much. For the most part, they rank the less challenging task, the symbol search task, as the most fun. And the most difficult or challenging measure, the shopping list test, as the least fun, which is kind of interesting. And they became at least somewhat bored with the brain games over the course of the 8 days of testing. About 82% said that using the phone itself was very easy, and another 15% said it was somewhat easy. And specifically, 90% said the app was very easy to use, which is really great. 36% said it was easy to remember to keep the phone on them. And really, really encouraging for my research in particular, about 80% said that they would consider doing these sorts of games as part of an annual cognitive screening in the setting of their primary care provider's office. So far, so good. So I've still got a lot of data collection to do, and I'm actually bringing people back into the clinic now so that we can look at how their performance compares on the in-person tests versus the remote tests. And I'm just starting to look at some of the online ORCA test data. So those are my next steps. I want to just thank the program, the Memory and Aging program here, and my mentors for the Alzheimer's Association grant. And then here are some of my team members, my research assistants, volunteers who've been helping me with the project, and research fellows at the Penn State Center for Healthy Aging.
Thank you so much, Dr. Thompson, for this presentation. It was very illuminating, and really appreciated you sharing some of your work and some background for it as well. Perhaps once more data is collected too, we could have you back to talk about some future findings.
Yeah, I hope so.
All right, great. And for everyone here, I have recorded this presentation and I'll make it available on our website for anybody that would like to review it again or share it with any colleagues of yours.
Okay, well, thank you so much, all of you, for coming. And I should have put my contact information up here, but I also, Justin, I imagine you had it in the schedule. So if anybody has any questions, please reach out, let me know.
Yes, absolutely. And if you cannot find Dr. Thompson's contact information, please feel free to contact myself. I am the contact person from the event invitation, so I can connect you. All right. I hope everybody has a wonderful day, and thank you again, Dr. Thompson.
Thank you. You too. Take care.